Ben Sessa, up to you.
Brilliant. Wow. Okay. Thank you very much. Great introduction. Goodness me, I hope I passed the test. It feels as if I have a lot to live up to tonight. I will do my best. Okay, well, thank you so much for having me here today. Firstly, I feel I'm rather scruffy for such a nice venue. I've never come to a psychedelic meeting where I've had to walk past a couple of guys with I have been wearing a shirt and tie all day, this addictions conference, and I thought I was going to be talking to a bunch of scruffy-looking hippies tonight. Far from it. So great pleasure to be here tonight. And thank you for having me here in Belgium. It's been a fab day, and this is the icing on the cake. So, do I have my deck? Whoa, here we are. Okay, so a little bit about myself. I am a medical doctor. I'm a child and adolescent psychiatrist by training. Spent 10-15 years working in child and adolescent psychiatry, where I worked with maltreated and abused children. I think every adult psychiatrist should spend at least 5 years in child and adolescent psychiatry. What I learned in terms of developmental psychology has hugely informed my life as an adult psychiatrist and an addiction psychiatrist. So I did that for 10 years. I've always, since the beginning of my time in medicine, had this equal joint interest in both psychotherapy and psychopharmacology. So this naturally took me to the door of psychedelics. I became interested in psychedelics as a teenager. I was living in London and as a medical student in the 90s, and I was a DJ. So it's fair to say I had some exposure to the ecstasy rave culture. And then all the way through medical school and as a trainee psychiatrist, I knew all about the work of the 1950s and the early 60s, Stan Groff and Aldous Huxley and Timothy Leary and Humphrey Osmond, all of these pioneers. And I would always say to my tutors in psychiatry, what can you tell me about this work in the 50s where, LSD was going to be the next big thing in psychiatry? It wasn't a controversial drug. This was like cutting-edge biological psychiatry. And they all said, what are you talking about? You're crazy. That never happened. LSD, psychedelics, these are dangerous, addictive, killer drugs. The correct treatment for somebody, if they come into your clinic with LSD, is to tie them to the bed and inject them with fluidazine. So this basically had been missed off the medical curriculum for my generation as psychiatrists. So in 2004, when I was a trainee, I wrote the first paper published in the British medical press since the 60s on psychedelics. And then this became, and then I sort of started going to conferences. I went to Albert Hoffman's 100th birthday party, and then I met everyone at MAPS and the people that then became Compass Pathways. And it was a very, very small community in those days. I was the only doctor interested in it. I was invited to meet Professor David Nutt, who's a professor of pharmacology in Bristol at the time, and we started working together. And I got involved in psychedelic research. I was a very big fish in a very, very small pond at the time, so it was fantastic. I was writing papers, getting editorials done, and then working with David on the UK's first psychedelic human drug pharmacology study, when David Nutt injected me with intravenous psilocybin in a mock scanner in 2007. And then since then, through Imperial, worked on projects with LSD and psilocybin and DMT, ketamine and MDMA, receiving all of those drugs and administering them. And so both the healthy test subject and the study doctor on all those studies. And that's quite good to be able to say that, because I get asked a lot, especially by journalists, so have you ever taken psychedelics? And I can actually put my hand up on the record and say, yes, I have taken LSD, DMT, psilocybin, ketamine, and MDMA, legally, all in legal settings, which is quite a good thing to be able to say to those people that say, you can't talk about this subject if you don't have personal experience. Now, I may or may not have additional personal experience. So my work in child adolescent psychiatry has been informative. And at one point I was doing work in lots of different places. I was working in an ADHD clinic. I was working in a PTSD, post-combat trauma clinic. I was working in general psychiatry on an inpatient ward. I was studying in the psychopharmacology department, doing psychedelic research. And all of these drugs, all of these different jobs, and I was doing psychotherapy, seem very disparate, but they are all tied together by trauma. And this work around trauma and developmental psychology has informed my career all the way through, and is all tied together by that. And has also, in answer to some things he said, informed my opinions around the concept of categorical diagnoses, or the uselessness of categorical diagnoses. And also, to answer one of your questions on that slide, where we go from here, I think we despecialize. I don't even believe in the concept of dual diagnosis. Everything is triple, quadruple diagnosis. There is a peculiar American split. Americans have very negative views of psychiatrists. They're just guys who give out drugs, or are ladies who give out drugs. My whole training in psychiatry from day one has been psychological and psychotherapeutic and social. My choice, if I didn't get into med school, was to be a social worker. You cannot be a good psychiatrist if you are not interested in your patients' family, children, hopes, dreams, aspirations, race, where they live, their housing, their financial situation. A ton of Prozac ain't going to get you better if you live in a lousy house with poor education and an awful life expectancy and fulfillment. And a ton of LSD won't help either. So we need all of these things. It's not either or, it's both and in every case. So, I would argue we are in psychiatry today where we were in general medicine at the end of the 19th century. So, at the end of the 19th century, modern general medicine was losing the battle to the infectious diseases. We were really good at medical epidemiology back then. We knew who got smallpox, who got tuberculosis. We knew people died after they had surgery, but we didn't know why. And we treated them with all kinds of oils and tinctures and symptomatic things to make them feel better, but they kept dying. Then we discovered the microbiology. We discovered that there were bugs causing this. And then at the turn of the 20th century, we discovered antibiotics, and we started to win the battle against infectious disease. Finally, humanity was winning the battle against infectious disease because we had antibiotics that attacked the cause, not just overlaying symptoms. Now, I'd argue that's where we are today in psychiatry. Bristol, particularly, the most wonderful psychiatric epidemiology department. We're wonderful at tracking anxiety, depression, eating disorders, personality disorders, addictions, affective disorders. Who gets them? We actually do know the cause as well. It's almost predominantly always something to do with trauma at some point. But our treatments are poor. Our outcomes are lousy. We treat the symptoms, we don't treat the cause. So the question is, where, and of course the psychopharmacology, the pharma industry, queue up to give us these daily maintenance medications to hold back the symptoms that don't treat the cure. Now this make this very clear, I am not an anti-psychiatrist. Joanna Moncrief's a good friend of mine. I am not an anti-psychiatrist. There is a place for SSRIs, there's a place for antipsychotics, there's a place for mood stabilizers, there's certainly a place for sedative drugs. And they do work in many, many patients. And traditional psychiatry with psychotherapy is very good for many people. But we have painted ourselves into a corner in the last 40, 50 years with this predominantly top-down biological model of medicines you take day in, day out for weeks, months, years, decades to hold back the symptoms but not treat the cure. After 100 years of modern psychiatry, this is not good enough, okay? This is not good enough. I feel ashamed on behalf of the profession of psychiatry that we are doing so badly. You know, we've been around for 100 years. There are no other branches of medicine that would accept the kind of outcomes that we do in psychiatry. Imagine oncologists, orthopedic surgeons, or cardiologists accepting 90% treatment resistance like we do in certain psychiatric disorders. It's outrageous. And it's because, where is our antibiotic? We are missing the wood for the trees in treating things symptomatically. So, you know all this, but I thought I'd start with a little bit of a brief description. Taxonomy of Psychedelics will get a lot of condor feathers ruffled in the hippie community. Sometimes people refer to psychedelics with a capital P as the classic psychedelics. So these are the 5-HT2A partial receptor agonist drugs, LSD, psilocybin, DMT, and mescaline, which are the biggies, but there's more coming along all the time. Everyone's talking about 5-MeO these days. These are what we would, and many people, when they use the term psychedelic, they mean the classic psychedelics. The entactogens, of which I'm most interested in, MDMA is the most well known, but there's a whole load in that series, MDA, MMDA, the 2C series. Dissociative anesthetics, can't talk about Bristol without talking about ketamine and nitrous oxide. Associative anesthetics have been around a very long time. Phencyclidine was around since the 1920s and used clinically since the 60s, then was replaced by ketamine. It's an NMDA antagonist, completely different mode of action. So I'm separating them all here by their receptor actions mostly. Tetrahydrocannabinol, you try intravenous THC with no CBD, tell me that's not psychedelic. Ibogaine, salvia, there's a whole host. So the real purists will say psychedelics are LSD, DMT, psilocybin, the 5-HT2A ones. But my argument would be, if we define psychedelics as drugs which alter a state of consciousness and allow us to do work in that clinical setting to improve patients' lives, then we have to broaden that definition beyond just the classic psychedelics. And there's a lot of people who get very bothered by even calling MDMA a psychedelic. I've seen MDMA behave very, very like LSD, and even THC, as I say. So that's one way of classifying them, according to their receptor sites. Another way of classifying them is their structure, and most of them fall into these two broad groups of the phenethylamines and the tryptamines. Now, of course, tryptamine and phenethylamine are endogenous brain chemicals. They're part of the synthesis pathway for neurotransmitters, which has led a lot of scholars to believe, wow, there must be an endogenous psychedelic. There must be some kind of psychedelic drug that either is produced in the brain or acts in the brain and explains non-drug psychedelic type experiences, like religious or spiritual experiences, near-death experiences, meditation, and there quite possibly is. I mean, let's face it, if you're a material reductionist like I am, then there's a psychological, electrical explanation for everything, including the love I'm feeling for you all now. But, do you know what? So Richard Strassman, a friend of mine, wrote a book in 1995, sparked this whole psychedelic renaissance thing off, the DMT, the spirit molecule. A wonderful book, wonderful psychiatrist. He wrote about using intravenous and intramuscular DMT for the treatment. It was a dose-response study in healthy volunteers. Very, very good science all the way through, until he gets to the very end, and then he says, oh, and it must be about the pineal gland, the mysterious pineal gland. And the entire psychedelic culture has embraced this idea of this mysterious pineal. There is nothing mysterious about the pineal gland. We know all about the pineal gland. It's a very, very boring central midline structure that produces melatonin in response to light from the retina and regulates the sleep-wake cycle. And Rick, in his book, said, well, it must be something to do with the pineal gland because the pineal gland appears on day 49 of the developing fetus, and there are 49 levels to the Tibetan Bardo. It's like, what? I've just read like 260 pages of great science, and you come up with this. And the psychedelic community love this. Now, this poor little pineal gland, since 1995, has been worshipped by the psychedelic community as the site of consciousness. It's been EEG'd, fMRI'd, electrophoresed, mashed, smashed, post-mortem. Not a drop of DMT is found in there. Now, DMT is a pretty good candidate for an endogenous psychedelic because it works at a pretty low dose. It's nowhere near the potency of LSD, and it's very, very close to serotonin. But if it's going to be produced anywhere in the human body, it's not going to be produced in the pineal gland. Pineal gland is 6 millimeters long. You need at least 17 milligrams of DMT to get a reasonable psychoactive effect. So we've got loads. Most of our serotonin is in our gut and our lungs. Much more likely if it's produced anywhere, it's there. And we also know about classic psychedelics. They don't act in the pineal gland. They act in the cerebral cortex, in the layer 5 pyramidal cells. So who knows? But from a materialistic reductionist point of view, there probably is an endogenous psychedelic that is produced probably on one of these synthesis pathways from tryptamine or phenethylamine. And there's some really, really interesting work that's been done. A guy called Edie Fitcher is doing some work with DMT. He wants to campaign in Brazil to have a little vial of DMT on the crash trolley in every hospital. And just as someone's about to die, you inject them with DMT to send them away. Okay, so there are so many different ways of describing psychedelics. This is the point. This is why they're so multidisciplinary. They have different names according to where you come from. Psychiatrists, rigid doctors would call them brain toxins. Psychotomimetics, hallucinogens. They create an organic psychosis. Indigenous people, religious people, spiritual people would call them sacraments, and we have the name entheogens. Timothy Leary and the like would call them saviours of humanity, brought to us by the aliens to save the world. The plant spirits have come to us. That's what they are. From a legal, political perspective, these are dangerous, banned, illegal drugs that destroy individuals and society. Gateway drugs to harder things. A great paper came out about cannabis about 10 years ago now, called Cannabis the Exit Drug. Increasingly, psychedelics and cannabis are being seen as exit drugs. These are drugs to get you off nasty drugs, not to get you onto nasty drugs. Probably the greatest gateway drug is tea. Agents of cultural change, and this 1960s idea of we can all just drop acid and live in chemical utopia, it's not going to happen. So many different things, but this is the one I'm interested in, that these are agents for clinical and consciousness research. We can learn so much about mental disorder and so much about the normal working of the human brain. Now, taking this developmental approach that I do, in my opinion, the main reason that most mental disorders become chronic, lifelong, unremitting disorders is this sense of stuckness, this sense of rigidity that forms very early on as a result of a disordered attachment. And it's very, very hard to change personality. A few years ago, we used to talk about it being impossible to change personality. And the stigma that went alongside personality disorders when I was doing my training 25, 30 years ago was you can't cure personality disorders. Now, we've moved on from that. And I think there's a lot of social and cultural work that's helped us move on from that. But it's very hard to change personality. Sometimes I just want to shake my patients, you know? It's like, you are not a useless, worthless, terrible person. I'm really, really sorry that you were told that when you were that high. You should not have been told that. You are a great, wonderful, smart, clever, attractive, erudite, intelligent person. They're just like, no, I'm not, I'm useless. They're not going to change. But just as if, now I think I'm really nice. I've had a really good, strong attachment. I was loved and cared for. I think Ben Sessa is a nice bloke. Kind, friendly, generous, smart, intelligent, ridiculously handsome. I think all that about myself. And if someone came along to me and went, actually, do you know what, Ben? You're a mean, horrible, rude, ugly old bastard and everyone hates you. They just don't tell you. And actually, they're all lying to you and you mustn't trust anyone. I just wouldn't believe it if someone told me that. So why should my patients? And they won't. So this is why psychiatry is in this rut, because it's about stuckness and rigidity. And there are ways to get out of this stuckness. Religious conversion is one. We all know people who are horrible, mean old people, and then they find Jesus and they come back and they're all, woo, and quite irritated. That's one way of doing it. Organic brain disease, you get severe personality change with CDA or bang on the head or an injury like that. Or peak experience that we can induce organically and safely, like the psychedelic experience. This peak experience can result in this personality change. When it comes to addictions, this is the holy grail for sobriety. It's an ability to shift this stuckness. William James in 1902 said this: the only cure for dipsomania is religomania. Dipsomania is the old term for alcoholism. So he knew that back then. Bill Wilson knew this. Bill Wilson, the founder of AA, talks about the higher power. He's talking about LSD. He had 5 or 6 high-dose LSD experiences in the 1950s and 60s. So there needs to be a stick of dynamite to shift us. This is Roland Griffiths, who I think was probably at ICPR last week. I wasn't there, unfortunately. He gave psychedelic naive patients, healthy volunteers, psilocybin, and demonstrated extreme personality change that persisted at 3 to 4 year long-term follow-up. Major shifts in openness. And what they said was, the greater the spiritual experience they had with this single or 2 doses of psilocybin, the greater they had this sense of personality change. Now, this study, I think, is somewhat underlooked, because this could underpin the treatment of personality disorders going forward in the next few decades. We can change personality rigidly, drastically. Now, addictions have a very rich history in psychedelics. Indeed, the majority of the work done in addictions in the 50s was LSD psychotherapy for alcoholism. And this is Humphrey Osmond and Hoffer in the 50s and 60s at the Canadian Hospital which I won't even attempt to pronounce. Saskatchewan, Canadian hospital. There may be Canadians here. How do you say it? Saskatchewan. It's not so hard when someone else says it. So they were working with alcoholics, right? And now there's a well-known thing about alcoholism. There's a condition called delirium tremens, very dangerous condition. It's a metabolic condition. If you just stop drinking, if you're a heavy daily drinker and you just stop after a day or 2 or 3, at some point your body has a violent physical reaction. It presents with a flurry of physical symptoms, and vomiting and seizure, and about 10 to 15% of people untreated will die from this DTs. Now, another factor of the DTs is it produces this intense organic psychosis. And alcoholics sometimes call this hitting rock bottom. They see the devil when they have this organic psychosis. Now, Osmond, working in Canada, was at around the time that Sandoz was sending out these bottles of Delicid, LSD-25, and it says on the bottle, LSD-25 produces an organic psychosis, but perfectly safe. So it's like, well, why? We know that our alcoholic patients experience this organic psychosis, but they die from their DTs, or many of them do. But about 5 to 10% of people post-DTs just decide to never drink again. It sort of has a weird curative effect. So they said, well, we'll give them this, we'll induce an organic psychosis with this safe drug, scare the willies out of them, and see if it works. Now they did, and not only did it not scare the willies out of them, they quite liked it, but they had 80 to 90% abstinence rates at 12 months. That's unheard of in alcoholism, and it sparked the majority of work in the 50s and early 60s started in LSD treatment for alcoholism. So that's going right back. Now, Tony Krebs and Paul Johansson did a meta-analysis of the work of Osmond and his team a few years ago, and they found a very, very high effect size. So that then sparked, in modern times, Michael Bogenschutz to do a pilot study in which he used psilocybin. Most of the work with classic psychedelics in modern times is psilocybin, not LSD. For a couple of reasons. It's shorter acting. LSD's a long day. It's like a 12, 14-hour day. Psilocybin can be like 5 to 8 hours, so it's a bit easier. But the main reason is it's much easier to get past ethics committees. If you put a protocol with LSD in it, the ethics committee will jump. If you put psilocybin, they'll go, oh, yeah, what's that? Pass. So there's been far, far more work with psilocybin than LSD. So Bogenschutz found this. He found the higher the spiritual experience, the greater the mystical experience, the greater the sobriety. Matt Johnson, who's on the scientific board at the company which I founded, Awaken Life Sciences, he used psilocybin-assisted psychotherapy for nicotine addiction. Also found the higher the mystical spiritual experience, the greater the rates of abstinence. Smoking cessation, again, massive public health concern, terrible outcomes. Evgeny Kapitsky, who works at the Pavlov Institute in St. Petersburg. He's a lovely guy. I really would love to go and visit him, if for no other reason than to ring the doorbell at the Pavlov Institute. He used high-dose ketamine, and he found that the mystical spiritual experience, the higher the mystical spiritual experience, the greater the degree of sobriety for treating alcohol and opiate addiction. And Celia Morgan, who's also on the board with us at Awaken, she has carried out the world's first evidence-based ketamine-assisted psychotherapy study called ketamine-assisted psychotherapy, and again found those patients that had the greatest dissociative type experiences had greater levels of sobriety. So, rich history of psychedelics in addictions. But I want to talk about 3,4-methylenediamine. And in order to talk about MDMA, we have to go back to kids. Now, when we talk about child abuse and maltreatment, people often think of the big things, what we sometimes call big T trauma, physical abuse, sexual abuse, the stuff that hits the radar for social services. I always say don't take your eye off the ball when it comes to neglect and emotional abuse. They're profoundly damaging to a developing child. I don't love you. Your dad doesn't love you. Your sister and brother don't love you. Everyone in the family hates you, actually. You're stupid. You're fat. That picture you just drew, that's rubbish. Anyone could have done that. No one will ever love you, actually. I think you're unlovable. I think you might be the devil child. Now, nobody's being punched here. No one's being sexually abused. But that kind of drip, drip, drip effect over a child's early years, especially in pre-verbal years, is profoundly damaging to their psychological development. So it can cause profound disturbances to personality. And this is why, child psychiatrists bang on about two things: boundaries and attachment. And attachment is this blueprint, the fundamental parts of how we live our lives today. What is love? What is trust? What is friendship? Is it okay to drop litter? Is it okay to cheat? Is it okay to lie, steal? We learned that stuff when we were that high, and we really don't lose it. We really don't. You stay with those values. I can guarantee all your values you've got in the room here tonight, about how you feel about one another and society, you learn that stuff very early on, and it's hard to move it. So if you are lucky enough to have a secure attachment, you have these positive narratives about yourself: I'm a good person, I'm worthy, I'm lovable, and the world, people are good, I can be trusted, I can trust them, they'll look after me. If you have an insecure attachment, you've been hurt, you've been raped, you've been burned, you've been humiliated, which is one of the worst ways of hurting a child, then you have these negative self and world narratives. Now, when you live your life like that, your best option is just to numb yourself and block out the pain and soften the edges with dangerous drugs like crack cocaine and methamphetamine, dangerous drugs like heroin, and then even far, far, far more dangerous drugs like alcohol. Now, as we know, those of us that work in mental health, we work with people on the bottom rung of the ladder. There are multiple factors for mental disorders. Multiple risk factors stack up for you to display the end phenotype. And most of our patients have most, if not all of them. Because just to not have one of them can be a protective enough factor for you to not display the end phenotype. So it's the genes as well. Now, genes are annoying because genes are not evenly spread. So all the nice posh kids that went to the posh schools and have the nice friendly posh families, they've got all the best posh genes. And the nasty parts of town that's full of the drugs and misuse and the violence and the crime and the poor education and the terrible schools, all the poor genes are over there as well, all the genes for depression and anxiety. So if we were going to practice eugenics, which I'm not suggesting we do, we would get the posh people to mate with the less posh people and get the genes back together again. But the genes aren't even fair, but society is even less fair. So we have these multiple social things. And this is why to be a psychiatrist, you have to be a good social worker, because no amount of psychotherapy or medication is going to get your patient better if they live in this kind of place. But that sounds sort of depressing, but the other way of looking at it is, look at all of the opportunities for clinical intervention. Look at all of the ways we can turn people's lives around. We could empty half of the hospitals and half of the schools tomorrow by having good care for single mothers with children under 5. Because if we get that early attachment back right, we will provide this psychological resilience that will allow us to experience trauma later in life and not be overwhelmed by it. So it's really, really hard to treat trauma-based disorders. And I've intentionally lumped together PTSD, CPSD, addictions. We could throw anxiety disorders, affective disorders, eating disorders, all substance abuse disorders, and personality disorders. They're all the same. It doesn't matter. What we do is we treat them symptomatically. So we have this polypharmacy. So the patient feels a bit depressed, we give them an antidepressant. They can't sleep, we give them a hypnotic. Their mood goes up and down, and we give them a mood stabilizer. Their hypervigilance, one of the core features of PTSD, spills over into paranoia. We give them an antipsychotic. So by the time they come into the clinic with an addiction, they're on 4 or 5 totally different classes of drugs, none of which are treating the cause, which is the underlying trauma. They're treating the overlying symptoms. And the classic example here, going back to our infection analogy, if you have an infection, one of the symptoms of an infection is a fever, a high temperature. Now you can take, high temperatures are lousy, you feel really ill if you've got a high temperature. Now infections are due to a bug, microorganism. You could take paracetamol, ibuprofen, aspirin. These are great antipyretic drugs. They'll bring your temperature down, you'll feel a little bit better. But those are not antibiotics, those drugs, paracetamol, ibuprofen. They're not going to kill the bug, but they're going to make you feel better. And when we tank our patients up with daily mood stabilizers, antipsychotics for non-schizophrenia, SSRIs, we are papering over the cracks with daily maintenance medications which they take for days, weeks, months, years, decades, without killing the bug. You can totally see where this is going. And the outcomes here are really poor. As I said, can you imagine oncologists, orthopedic surgeons accepting these kinds of outcomes? Immunologists, endocrinologists, no, they would not. 70 to 90% treatment resistance in AUD. After the very best modern medicine can throw at the post-detox alcoholic, 90% are back to drinking what they were pre-detox at 12 months. That's outrageous. We were better at treating alcoholism in the Victorian times than we are today. PTSD, 60, 50, 60% treatment resistance. Unreal. You go into your psychiatrist in your early 20s with whatever, anxiety, depression, PTSD, addictions, you are probably going to be going back to that psychiatrist in your 60s or 70s. That is not good enough. I want to be an orthopedic surgeon. I want to get that patient in, I want to mend that broken knee, kick them out and never see them again in my clinic. But instead I'm a palliative care doctor. I hold their hand for life. You know, I'm sick of being alongside people. I want to discharge them well. Sorry if I'm ranting a bit. I don't want to be an orthopedic surgeon, I'm way too sophisticated. So, how does MDMA work? Well, a lot of people think it raises serotonin. I mean, it's a bit more sophisticated than that.